we talk about the second part and the most important here today, which is wound healing. To imagine the wound healing process, you have to imagine as it, you have a building reconstruction place, okay? Your skin is a guard or a wall that protects the whole body, okay? So when this wall is broken, or this guard is broken, or you have an opening in this wall, something have to happen. Something have to happen. First event, or the first step, or the first stage in wound healing have to be either hemostasis to stop the bleeding, what happens when you cut the skin, and inflammation. So it's have both terms, in hemostatic, inflammatory phase. You already know that hemostasis starts with cutting injury, bleeding, then you have blood vessel constriction, trying to stop the bleeding vessel, then platelet activation, coagulation cascade happens, then clot formation, and this is the end of this stage. Okay? Together with it, in the same time, you have inflammatory stage. The first here to arrive are the macrophages. And here the macrophages is, we can say, the master plan, the mastermind of the process, who will direct all the process afterward. First function for these macrophages is to provide protection against the external environment. Your wall is broken, you have a wound, you are exposed to the external hazards, other bacteria, infection, whatever. So who will come and close this gap? Who will come and protect you from the outside enemies? Our soldiers, the macrophages. Okay, so the first function for these macrophages is to protect the body against bacterial invasion of this wound. The second and very important function is to modulate the healing process. After it arrives, the macrophages, it begin to produce a pro-inflammatory cytokines and growth factor release, which will mediate all the process afterward. It goes after the first vasoconstriction and fibrin clot formation. It begin to form a vasodilatation, and we know why. Cytokine release, angiogenesis, fibroblast activation, B and T cell activation, keratinocyte activation, and wound contraction. To begin to enter the second stage. First stage, you stop bleeding, you protect the body from any bacterial invasion. Afterward, you need to build this wall again. Afterward, you have to repair this wall again, the skin, of course. To do so, you have to bring the workers, you have to bring labor, you have to bring people who can build this. Here, our people, our workers, are the fibroblast. The fibroblast activate the fibroblast in the place and retrieve fibroblast from the nearby skin and nearby tissues. These fibroblasts, with increase in its number and increase in its activity, needs more blood supply. So comes the new genesis, new angiogenesis. New vessels, new capillaries start to form in this area to supply these fibroblasts with their needs of blood supply, their needs of building materials. Okay, and here come, we are forming the proliferative phase, the second stage, the granulation proliferative phase. Here we have fibroblast migration, collagen deposition, neoangiogenesis, granulation tissue formation, followed by, after granulation formation, epithelialization, covering this granulation tissue with epithelium, or the epithelial cells or epithelial layer of the skin, followed by contraction. And here contraction is very important if it can happen. If you have a large wound or a gaping wound, to facilitate on all these workers, all these fibroblasts, all these epithelial cells to work and close this wound, you have to decrease its diameter. And this can happen by contraction of the wound. The wound can be contracted, decrease in diameter, decrease in width, and so its closure becomes more easy for these cells to do. After this stage complete, you enter in what we call remodeling stage. You've done a very excessive work, you have excessive blood supply, you have excessive fibroblast, you have excessive fibrin deposition. All of these processes left us with excessive tissue in this scar. So the body have to remove this excessive tissue. First, we have to regress the overformed capillaries. The blood supply return to less than normal. Physical contraction by myofibroblast, collagen degeneration and sensation. Part of the collagen are degenerated, other types of collagen appear more strengthened than the first collagen formed in the wound, and new epithelium is formed. The first epithelium are changed and the new epithelium is formed. And at the end of this stage, you can gain a tensile strength of maximum 80% of the normal skin. Okay, so our 3 steps, our famous 3 steps of wound healing are the hemostasis, inflammatory phase, proliferative granulation phase, and remodeling phase, the third phase. We have also type of wound healing. We have the healing by primary intention, which is we see in the simple healing after suturing the wound. The wound edges are in front of each other, no gap. So all the body need is to heal or يعني mold these 2 edges of the wound in front of each other. So this process needs very, very, very little fibrosis, and so on. It will leave very little scar, or acceptable scar. But on the other hand, if our wound is gaping and the edges are not in front of each other, what will happen is that the body, by the process of healing that we explained earlier, will close this gap by fibrous tissue. And this means that all this fibrous tissue is a scar. And whenever you increase fibrosis in the skull, this skull will become more ugly, more unacceptable. Okay? And of course, it needs much more time for this healing, type of healing, or second intention healing to occur. But what about healing by tertiary healing? What means here by tertiary healing? That your interference, like suture we done in primary healing, are delayed. Here is a gaping wound. Here is a granulation tissue formed in this wound, and here you remove this granulation tissue and interfere either by removing this granulation tissue and primary or closing the wound by simple suture, or by doing a reconstructive procedure, like skin graft, skin flap, or whatever. There's many factors that affect wound healing, of course. Some of them are local, some of them are systemic. The local factors are ischemia, of course. If there's no blood supply here, or deficient blood supply, of course, all this process will be affected. Infection will delay that. You become stuck in the first stage. You cannot enter the second proliferative stage until you have clean wound. Body have to eliminate infection first. Foreign body, of course, will affect the healing. Edema, and elevated tissue pressure. What about systemic factors? Of course, age and gender, sex, hormones, stress, ischemia, diseases, obesity, medication, alcoholism and smoking, immune compromise, of course, and nutrition. All this will affect your wound, either by delaying or accelerating wound healing, or by stopping, even stop wound healing completely. What about the complication of wound healing? Some complications are early, some complications are late. From the early complication we have seroma, which is a collection of serous fluid underneath the wound. Hematoma, of course you know, a collection of blood. Wound disruption can happen. Superficial wound infection, deep wound infection, mixed wound infection. The seroma, you will see that space formed underneath the wound filled with serous fluid, lymph or blood. You can feel fluctuation, swelling, redness, tenderness, and subfibrility. Trauma can be treated by sterile puncture or compression in the same time, and may you need suction drain. Hematoma is, bleeding, short drainage time, no anticoagulant. Here increased stubborn risk of infection. You have swelling, fluctuation, pain and tenderness. Of course, it can be sterile puncture in early cases, or surgical exploration if you have still a bleeding vessel. Wound disruption may be partial or complete, but its cause may be surgical error, increased intra-abdominal pressure in case of wound in the abdomen, wound infection, or hyperproteinemia. And the treatment usually is resuturing with a wide U-shaped sutures. Wound infection or superficial wound infection may be diffused or localized. Okay? Treatment will resting position, antibiotic, dermatological consultation. Localized surgical exploration, here we have localized, we are talking about a sort of abscess formation, so you have to explore, drain, and put a drain for a while if you need it. Deep wound infection inside may be also diffused or localized. It's treated by surgical exclusion, open therapy, and hydrogen peroxide and antibiotic irrigation of the wound in both cases. What about leg complication, which is much more common and much more important? The most two famous are the hypertrophic scarring ankylosing formation. You may have necrosis of inflammatory infiltration, abscess formation, foreign body, all of these can happen, but the first two are the most important here. And simply, the hypertrophic scar is developed in area of sacroilium, non-hyaluronic collagen fibers and fibroblast are formed, confined to the incision line. This is very important. Your hypertrophic scar, whatever it's big, whatever it's ugly, it's confined to the incision line. the things that you don't find in keloid. Keloid does not respect the incision line. But in keloid, you have racial predation. Mostly African and Asian population suffer from keloid. You have well-defined age, emerging tooth structure, overproliferation of collagen fibers in the subcutaneous tissue, and subjective complaints. And of course, as I said, it's not respect the incision lines. Hypertrophic scarring usually regress spontaneously within 1 or 2 years. The only treatment is supportive treatment by creams or silicone compression, but it will fade. It will regress by itself, even if you don't treat it. On the other hand, keloid never regress by itself. But in the other hand, it failure rate of treatment reach 70%. 70% failure rate of treatment. But you can treat it well. Corticosteroids, local anesthetic injection, plus local anesthetic injection, and post-operative radiation. And this will be all in our day-to-day. Thank you.